welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Sonam Puri from Moffitt Cancer Center, lead author on Therapy for Stage 4 Non-Small Cell Lung Cancer with Driver Alterations, ASCO Living Guideline version 2026.3.2. Thank you for being here today, Dr. Puri.
Thanks, Whitney. Excited to be here.
And then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Puri, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to jump into the content that we're here today to talk about, Dr. Puri, this living clinical practice guideline for systemic therapy for patients with stage 4 non-small cell lung cancer with driver alterations is updated on an ongoing basis. What prompted this latest update to the recommendations?
Thanks, Whitney. It's always exciting to update the guidelines based on ongoing data. That's the great part of being on the Living Guideline panel. But for this particular update, beyond our routine literature review, our update highlights important revisions to the recommendations for NTRK rearrangement and HER2-activating mutations in non-small cell lung cancer, reflecting really the new practice-changing evidence that has emerged in both settings.
Great. And then, as you just mentioned, there's new practice-changing evidence for both NTRK and HER2 alterations. So starting with NTRK, what updated evidence did the panel review on first and second-line treatment options for patients with stage 4 non-small cell lung cancer in an NTRK rearrangement, and how did this impact the recommendations?
So for NTRK fusion-positive non-small cell lung cancer, the panel added repotrectinib, tyrosine kinase inhibitor, as an option for both first-line and subsequent therapy. This recommendation was based on the published results of the phase 1/2 TRIDENT-1 trial, which looked at repotrectinib across NTRK fusion-positive tumors and included a large population of non-small cell lung cancer patients with a confirmed objective response rate as the primary endpoint. The study showed that the confirmed objective response rate was great in both treatment-naive and TKI pre-treated group of overall population and non-small cell lung cancer. And the study showed a confirmed overall response rate of 59% in patients that were TKI-naive and 48% in patients who had prior exposure to a TKI. So what really stands out for repotrectinib is the intracranial activity, plus repotrectinib is also really effective against certain mutations that emerge when a patient is treated with a tyrosine kinase inhibitor known as solvent front mutations. Repotrectinib actually works for certain mutations that emerge for patients who have received prior TKI. And for that particular population, repotrectinib showed a 53% response rate. And that makes it genuinely useful option for post-TKI setting, not just first line.
Excellent. It's great to have this new option both for the first line and for the second line, as you just described. So then moving on to that second set of evidence that the panel reviewed, what updated evidence did the panel review on first-line treatment options for patients with stage 4 non-small cell lung cancer and a HER2 activating mutation, and how did this impact the recommendations?
Yeah, so for HER2 activating mutations, the panel added zongertinib, an oral irreversible HER2 selective tyrosine kinase inhibitor TKI, as a first-line option for patients with HER2 activating mutation. That recommendation comes from the published results of cohort 2 of the phase 1A, 1B Bumion Lung 1 study, which enrolled patients that were treatment naive with HER2 activating mutations with a primary endpoint of confirmed overall response rate. The study showed a response rate of 76% in the treatment naive group. And there was also a separate cohort 4, that looked at patients with active brain mets. The results showed that zongertinib in this population of patients was associated with an impressive intracranial response rate of 47%.
It's great to have this new option for patients with HER2 activating mutations as well. So then both of these add new options in the treatment arsenal for patients with stage 4 non-small cell lung cancer. So what should clinicians know as they implement these updated recommendations, choose between these options, and how do these changes impact patients?
Absolutely, Brittany. I think we cannot stress more that testing has to come first and it has to be complete. Neither of these recommendations matter if NTRK fusions and HER2 activating mutations aren't picked up. That means that we have to focus on broad upfront molecular testing at diagnosis, not sequential single gene testing, because both alterations that we discussed about today are uncommon enough that they'll be missed if testing is narrow or reflexive testing is skipped. Also, what is important is sequencing and prior therapy. For NTRK fusion positive disease, repotrectinib activity holds whether a patient is TKI naive or has already seen a prior generation of a tyrosine kinase inhibitor, including activity against solvent front mutations. This gives clinicians a viable option after progression on earlier generation TKIs, which was not reliably true before. Lastly, I would like to say that for both of the drugs, what really stands out is CNS activity. Both zongertinib and repotrectinib that we discussed today have good intracranial activity, which is a genuine practical advantage for patients, as we know that intracranial metastasis is associated with high morbidity and mortality in non-small cell lung cancer.
Absolutely. As you mentioned, biomarker testing is absolutely essential for these patients, and it's great to hear that there is intracranial activity for these two new drugs that are added to this guideline. So then, as you mentioned before, this guideline is living, meaning that the evidence is reviewed on an 8-week cycle. So what evidence is on the horizon for future updates to this guideline?
Yes, the excitement definitely never ends for our panel as new updates come forward. But for the particular genetic alterations that we discussed today, specifically the HER2 activating mutations, the HER2 recommendation really currently rests on single-arm cohorts. So randomized phase 3 data for treatment-naive HER2 activating non-small cell lung cancer is something that's brewing, which is going to be on our watch for sure. Also, sivabertinib is another selective HER2 TKI that has data for patients with HER2 activating mutations, and data for that is also maturing, and we'll see how it positions around zongertinib. And because it's a living guideline, any practice-changing data in other alterations such as EGFR, ALK, ROS1, RET, MET, KRAS could really trigger the next update. We watch each conference and each publication so closely for all of these.
Definitely. We'll look forward to new evidence as it gets presented and published and inform future updates of this living guideline. So I want to thank you so much for your work to rapidly and continuously review the evidence for this guideline. And thank you for your time today, Dr. Puri.
Thanks so much.
And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.ascopubs.org/guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.